53 randomized controlled trials, 68,128 participants. Every trial running a year or longer, analyzed by researchers at Harvard. The conclusion: low-fat diets do not produce more long-term weight loss than higher-fat diets of similar intensity. In the lead author's own words, there is no good evidence for recommending low-fat diets. I'm Dr. Padda. Let's go through the fat evidence properly. That meta-analysis is Tobias and colleagues, published in Lancet Diabetes and Endocrinology in 2015. I'm naming it precisely because this study gets misattributed constantly, including in slide decks I've seen presented by people who should know better. Then there is the Women's Health Initiative, one of the largest randomized dietary trials ever conducted, 48,835 postmenopausal women, 8.1 years, a low-fat, calorie-reduced diet with increased physical activity. The intervention worked in the sense that the women actually did it. Total fat intake down 8.2%, 361 fewer calories per day. Sustained for 8 years. The result? No significant weight loss. No reduction in coronary heart disease. No reduction in stroke. That is what a well-run, well-funded, well-adhered to test of the low-fat hypothesis produced. Nothing. Here's the mechanism the guidelines missed. Fat is satiating. It also has the least effect on blood glucose and insulin of the 3 macronutrients. Protein has more. Carbohydrate has by far the most. And excessive insulin production, followed by insulin resistance, is the precursor to type 2 diabetes. It is the actual disease process. So the 1977 recommendation to hold total fat under 30% of calories did something worse than fail to help. It pushed an entire population toward the one macronutrient that drives the insulin response, and it removed the one that turns appetite off. Now the hard one, saturated fat. In 2014, a meta-analysis of 76 studies covering more than 600,000 participants across 18 countries concluded that current evidence does not clearly support cardiovascular guidelines, encouraging high consumption of polyunsaturated fats and low consumption of total saturated fats. The following year, D'Souza and colleagues in the BMJ found that saturated fat intake was not associated with all-cause mortality, cardiovascular mortality, total coronary heart disease, ischemic stroke, or type 2 diabetes. Not associated. That is a systematic review talking, not an advocate. And in a 2015 randomized comparison, diets using cheese and meat as the primary sources of saturated fat produced higher HDL cholesterol and higher apolipoprotein, A1 than a low-fat, high-carbohydrate diet, a less atherogenic profile, not a worse one. Dairy fat is the clearest example. In cohort data, plasma saturated fatty acids from dairy sources, cheese, yogurt, milk, are inversely associated with incident type 2 diabetes. More dairy fat, less diabetes. A separate cross-sectional study found people in the highest hurdle of whole-fat dairy intake had significantly lower odds of obesity. I'll flag the limitation myself. Cross-sectional data shows association, not causation. And we cannot rule out that healthier people simply choose differently. But notice the direction of every one of these findings. It is the opposite of what you were told. The pattern underneath all of it is this: fat that arrives inside real food, packaged with the vitamins, minerals, and antioxidants that evolved alongside it, behaves very differently from fat that has been industrially extracted, heated, deodorized, and bottled. Your great-grandmother ate saturated fat freely, without restriction, and she was not the generation that got sick. So if saturated fat isn't the driver, what is? Replacing saturated fat with omega-6 vegetable oils does reliably lower LDL cholesterol. What it does not reliably do is improve cardiovascular mortality, and in some analyses, mortality moved the wrong way. Lowering the marker did not deliver the outcome, which should tell you the marker was never the mechanism. Total and LDL cholesterol are poor standalone predictors of cardiovascular risk. Elevated triglycerides and low HDL predict better, and that combination is a reliable signature of insulin resistance. Worth knowing, the Q risk calculator, used across the UK, doesn't use LDL at all. It uses the total cholesterol to HDL ratio. And here is the number that reframed this for me. Using the Archimedes simulation model on national survey data, researchers estimated that in young adults, preventing insulin resistance would prevent 42% of heart attacks. Compare that with correcting hypertension at 36%, low HDL at 31%, body mass index at 21%, and LDL at 16%. That is a model, not a trial, a simulation, and I want that stated clearly. But every arrow points the same way. Insulin resistance is the largest single modifiable driver, and it is the one we test for least. Next video, the 3 ingredients actually doing the damage and what oxidized seed oil does inside a human body. Padda Institute Center for Interventional Pain Management, 4477 Woodson Road, St. Louis, 314-481-5000. Educational only cars. Do not change medication without your physician.